Hi, good morning, everyone. I think we're going to get started. This is Nancy Kelly from the New England QIN-QIO. Thank you for joining us for the New England Nursing Home Quality Care Collaborative. I'd like to turn it over to Pam Heckman. Pam?
Good morning. Everyone, thank you for joining us. I'm Pam Heckman from the New England QIN-QIO, and I will be moderating today's webinar. Thanks for joining for today's webinar, A New Look at Incontinence. Before we get started, I'm going to quickly review a few housekeeping items. This webinar will be recorded and the presentation will be available in a few business days. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. Please do not put your line on hold during the webinar. We will have a few polling questions throughout the presentation. We encourage you to be ready to respond to each question. If you have a question at any point throughout the presentation, please will you enter it in the chat panel to the right of your screen. We will be monitoring and responding to questions and comments in chat, and we'll have time for questions at the end of the presentation. We will also have a Q&A during part 2 of this webinar, which will be held on Thursday, June 30th. Lastly, if you do find your presentation a little cut off on your screen, please use the plus or minus icon in the top of the presentation window and adjust accordingly. So let's move on to today's program. I'm happy to introduce Gail Harbour, who will talk to us today about incontinence. Gail works for the New England QIN-QIO in Vermont. Gail is a registered nurse and has over 35 years of experience in nursing. She has extensive experience in the long-term care setting and has held various roles throughout her career, including Regional Clinical Service Manager, Regional Director of Quality, Director of Nursing, and Director of Special Projects. Gail holds a Bachelor of Science in Nursing from Castleton College in Castleton, Vermont, and she is a registered nurse in the state of Vermont. Please welcome Gail.
Thank you, Pam, and thank all of you for taking time out of your busy schedules to join us today. I hope that we'll be able to share a couple of tips with you that will save you some time down the road. For our objectives, today, we're going to look at low-risk incontinence as it relates to other quality measures that affect the 5-star rating. Most of our quality measures are interrelated and do not stand alone. We will focus on irreversible urinary incontinence with an eye toward minimizing episodes and the related negative outcomes. So we hope to be sharing some ideas for staff and resident buy-in and for keeping it all real, individualizing our processes and making them doable. We'll talk about essential communication amongst shifts to promote success and the importance of assessing our interventions, documenting and revisiting unplanned and or unsatisfactory outcomes from our interventions. It isn't easy. I think we've all seen, heard, or even tried this approach. It may have sounded more like, I'll be there shortly, or sit down, I don't want you to fall. And the resident's response, which may actually end in a fall, is, when you gotta go, you gotta go. And no, I did not pose for this cartoon. They begged me, but I said no, and they had to find my double instead. So who are we focusing on today? Those residents who trigger the CASPER. Who are they? Low risk, we'll define that term in just a minute. They are our long-stay residents over 100 days in our nursing home who are frequently or always incontinent. When? What period of time are we looking at? It's a 7-day look-back period that's determined by the NDS nurse as the ARD, the assessment reference date. And what is it that we're looking at for frequently or always? Frequently is 7 or more episodes of urinary incontinence during that look-back period, and or 2 or more incontinence episodes of the bowels. Who is low risk? Who is counted in your CASPER numbers? The easiest way to look at these numbers is to describe who is excluded from your numbers. If a resident has any of the following high-risk conditions, they are excluded from this quality measure. Those who are severely cognitively impaired, totally dependent in bed mobility or transfer, or locomotion on the unit in self-performance. Those who are comatose, living with an ostomy, or living with an indwelling catheter. What do the numbers mean? I know that this is not new for many of you, but I think it's a good time to review how we look at our incontinent numbers from the CASPER. In this example, only 16 are included in the denominator because all others triggered as high risk. 10 of the 16 were frequently or always incontinent. And when you do the math, that comes out to a facility percentage of 63%. And then you have the opportunity, as you know on your CASPER, to compare it to the state and national percentages, and you'll see that you're not alone. The rates are high everywhere. The measurement of success, so data, plain old numbers are how we measure our success. We may not want to set a goal of reaching 0% on our CASPER, but helping a few residents to reduce their episodes of incontinence can show a pretty dramatic change in your CASPER percentage. We started with 10 out of 16 low-risk residents who triggered in the previous example. If we help 3 of them to reduce their episodes of incontinence, our numerator becomes 7, our denominator stays at 16, and we can now brag about a 20% reduction, and so it goes. If we help 4 residents, we're down to 37%. If we help 5 residents, we're down to 31%. So you've demonstrated a measurable improvement in measuring your incontinence. The CASPER trigger, I think these numbers are worth repeating because we want our staff to understand that success is possible. We are not expecting that residents with irreversible incontinence will become totally continent. Our goal is to minimize their problem. So again, during the 7-day look-back period, it's 7 or more episodes that we want to reduce of urinary incontinence and 2 or more episodes for bowel incontinence. That important look-back period. The MDS nurse is capturing the care provided in a 7-day period. His or her awareness of what triggers the quality measures can be essential in improving your numbers. In some instances, adjusting the ARD, that is Person's Reference Date that identifies the 7 days, can eliminate the unusual occurrence of incontinence. For example, an untreated UTI or 2 episodes of bowel incontinence related to a 24-hour virus. This kind of thoughtful analysis by the MDS nurse can help with all the quality measures. Your MDS nurses should be a key player in your quality program. They probably spend more time in their medical records than anyone else on your staff. So make sure that you embrace them in your team endeavors to improve your quality. Put them on your PIP teams. We really don't have the time today to go into managing bowel incontinence in depth. We do have a couple of quick tips to share. Remember, this trigger is 2 or more episodes in 7 days. We know that treating constipation with medication is frequently necessary and a common practice. This is an area that presents challenges because of the need not only for clear nurse-to-CNA-LNA communication, but the communication usually has to be transmitted across all 3 nursing shifts. If we can improve this communication, we are more likely to reduce bowel incontinence by timing the toileting and making sure that the appropriate equipment at bedside commode or nearness to the toilet are readily available. I wanted to throw out a request for a Part 2 sharing webinar that's occurring on June 30th. If any of you have a great tool or a method of communicating the use of laxatives or suppositories, please share it. You can scan it in and email it to your state lead. All help is welcome, and we're sure that all of you out there have a lot of experience that you can share with others. Back to our main topic of minimizing urinary incontinence. I'm sorry for jumping around a little bit, but that's how my brain works. As you know, providing information and knowledge that people need to make change is probably the easiest part of change. To get buy-in from the leadership and the staff, it's important to start with the why of it all and convince them that reducing urinary incontinence is win-win for caregivers, residents, and your organization in general. So in the next few slides, we'll share some thoughts about what's in it for everyone, information that you can share with your staff to help with motivation. In the United States, there's an estimated 10% to 35% of adults who have some kind of incontinence, and those are only the ones who admit to it. Over 50% of 1.5 million nursing home residents have some type of urinary incontinence, and there's a conservative cost estimate of $5.2 billion per year for urinary incontinence costs in nursing homes. That's a lot of moolah that could be used in other places. So for your organization, and as it trickles down, excuse the pun, to all of us, incontinence does not stand alone. It crosses over the other quality measures and can have a negative impact on your 5-star rating. When we review urinary tract infections, we find that most occur in residents who are incontinent. And when we do root cause analysis for falls, how often do we discover that the resident was on their way to the bathroom? And then there's that dark, moist environment that contributes to skin breakdown and even pressure ulcer development. We're all familiar with the cross-tagging that happens with survey. I've just listed a few of them here. When they get us into trouble with survey, they also have the risk to get us into trouble with finances. So 315 is the incontinence survey. It's frequently crossed with pressure ulcers, professional standards, accidents and supervision, assessment, care planning, dignity and respect, and infection control. For just a single tag of 315, the fines can be as high as $500 to $10,000 per day that cover that interpretive guideline, which include the improper use of indwelling catheters, prevention of UTIs, and the restoration of as much bladder function as possible. That's several $1,000s per year per resident on incontinent products and skin products. Yesterday, I'll just hold off on this slide for a second. Just yesterday, I got some information that the OIG fiscal year 2016 mid-year work plan, which was published this past Tuesday, includes plans to review medical records in the hospital for nursing home residents who were admitted with urinary tract infection. And the review will help to determine if facilities provided services to prevent or detect UTIs in accordance with the resident's care plan. So you can see that more and more everyone is looking at all of these things of incontinence and urinary tract infection as they relate to each other. So moving on again with what's happening and how to engage your nursing staff, take the time to spend motivating them, engage them, get them to share and think about how much time it takes for them to deal with a UTI, a fall, skin breakdown, or fixing deficiencies. Completing voiding diaries can be cumbersome, but that it will save time in the end. Help to instill some pride in their work by posting their successes and helping them to understand how their work is seen by the public. Help them to understand Nursing Home Compare, the star rating, and share your CASPER numbers with them. So for the LNAs and the CNAs, talk to them. Get and listen to them. It is time saving. Prompting and assisting residents with individualized toileting programs is faster than providing incontinence care and dealing with the potential complications. Help them to understand those complications, the UTI, falls, etc. Save time by ensuring that they will have bedside commodes, urinals, bedpans readily available for use. It's pretty frustrating to have to hunt down and maybe even clean a commode while the resident is sending you that message, gotta go right now. It's more pleasant and cleaner. They know that, but it's nice for us to acknowledge how unpleasant their work can be at times. Studies have shown a couple of interesting things about residents with dementia. If they remain somewhat mobile, many are capable of participating in a toileting program. Many residents with difficult behaviors exhibit fewer behaviors with an appropriate program. Actually, they prefer being invited to the bathroom as opposed to being subjected to incontinence care. Who wouldn't? And is the care safer? In one study done in British Columbia, the nursing assistant perceived that the physical work of assisting someone to the bathroom was safer than providing incontinent care. They felt less at risk to back injuries and neck injuries. And though this is anecdotal, related to a small study, it does make sense when you break down the physical steps of assisting with toileting and compare them to the steps involved with incontinent care. Preventing complications. What's most important? The resident. What's in it for the resident? The resident needs the education about the complications. If the resident doesn't buy into the program, it will not succeed. Some residents can even do their own voiding diary, but most LowRisk residents should be able to have at least an active participant to some extent. So we know about the complications. We help the nurses and the LNAs to understand the potential complications. But sometimes that resident who thinks it's easier to use a brief than the toilet, that person may not understand the rest. So when we document that they refuse to participate, we need to be sure that it is an informed refusal, that we've done the education. If the resident does not choose to be awakened at night for toileting and incontinence care, then we should care plan accordingly and try to reduce as many episodes during the daytime as we can. Or ask ourselves, what else can we offer this resident? For example, does the resident think to use a brief because he or she thinks they'll have to walk to the bathroom in the middle of the night? Have we offered them a urinal or a bedside commode? If the resident doesn't buy in, then our goal is not person-centered and our goal will not be met. Okay, so here we have just a kindly wish and a frazzled nurse or LNA responding, I haven't even finished the previous year yet. I hope your infection control nurses, if anybody's watching this, that you don't have a heart attack looking at her choice of multitasking. But isn't this how we all feel much of the time? One more thing to do, and I haven't finished the last 3 projects. So we're going to proceed now and kind of look at what can we do to make it easier and to make it helpful. Sliding over the assessment or touching on the assessment process. Just as an aside, I want you to know that it's taken all of my self-control to avoid puns that have floated through my head on this topic. Get it? Floated. Never mind. Let's just move along. Let's look at a couple of things around the assessment process, even though our focus today is going to be on the voiding diary. We're not going to spend a lot of time looking at the major assessment you do when you conduct for admissions annually and with changes of condition, but it just feels wrong to completely ignore it. Our initial goal is to determine whether or not the condition we're treating is reversible and to do something about it. And to fix that, we need to identify it and quantify it. So take a look at your assessment protocols and make sure they're following the current standards of practice. Just a couple of reminders. Check with your staff about the practice of giving everyone briefs on admission, quote, just in case. Practice that enables incontinence from the very beginning. One other comment about the initial assessment process. I think each of us will admit that we would be reluctant to tell a perfect stranger that we have an issue with incontinence. It's about dignity. To the best of our ability, make sure the person doing the assessment is aware and sensitive. Gentle probing, aside from the assessment question, an empathetic attitude, and reading statements like it's very common, many women over the age of, many men over the age of, we want to know so that we can help you. Those kinds of leading statements will help get a more accurate picture. We do not want the surveyor to see an initial assessment where the documentation indicates that the resident was continent on admission, followed by CNA, LNA documentation that shows, guess what, the resident became incontinent during their stay with us within a very short period of time. I speak from personal experience. It's a great setup for a deficiency. I also like this acronym that I seamlessly stole, DRIP. It's great for using with your staff or posting at your nurse's station because, as you know, new incontinence can occur at any time and needs to be fully assessed whenever it's identified. So, going back to the focus of irreversible incontinence, low risk, we need to look at the dreaded voiding diary. When I'm at nursing centers, I hear that they are cumbersome, that it's difficult to get the data that you need. So we hope to share a few hints and tips that might make it a little more user-friendly. Why bother with them at all? Well, it's a standard practice. It contributes to individualized care plans with resident input, and it enhances our ability to minimize urinary incontinent episodes for better care and improved outcomes. What are the components? What does it need to be? It needs to be accurate and complete. Covers 72 hours over all 3 shifts. Every 2 hours. It needs to be simple, but with enough data to find a pattern. It needs to be communicated to everyone and owned by the charge nurse on every shift. This is a sample voiding diary that we broke down a little bit. You probably cannot see it too clearly. It's not a whole lot different from what you've seen. We've made a few revisions to the Kansas Association of Homes and Services for the aging form. Resident identification and date of data collection are at the top. The first column is 24 hours starting at midnight. The next 3 columns are related to urinary incontinence with codes to circle for small, medium, and large amounts. And though we're not focusing on bowel incontinence, this form includes monitoring, then finally initials and comments. The codes are defined on the form to make it user-friendly. If you have a tool that works, that's great. If you want a closer look at this tool, you can find it at our website at www.healthcarefornewengland.org. If you have something to share, please scan and email it to your state lead. And just quickly, small, medium, and large for amounts. Comments in the comment column, your LNAs or nurses can put in AR, assisted with results, ANR, assisted with no results, RR, resident refused, RRQ, resident requested assistance, or any other relevant comments. And now, Nancy is going with our first polling question. We will use your responses to determine how we can best support you going forward. Nancy?
Hi, thank you, Gail. So as Gail mentioned, we're on to our first polling question. The question is, are you currently using a 3-day voiding diary that works for your facility? Is your response always, usually, sometimes, or never? Please press submit and select your answer on the right side.
Always, right?
Okay, we have a few more seconds here. Once again, make your selection, then press the Submit button on the lower right side of the screen. Okay, and we'll just wait to receive the results. Okay, and it looks like many people on the phone actually are always using a 3-day boarding diary that works for their facility, so that's great.
Okay, thank you. So here we have Nurse Gail leaning over her very sick patient. Try to get some rest. I'll be back every few minutes to make sure that you don't. I relate this more to the 2 times I was a patient than some of the millions of years I've been a nurse. I do love my sleep, but enough about me. It really does help to get the resident on board with the toileting program. Waking people up in the middle of the night may not exactly be, quote, person-centered. It will help if they are made aware of the duration of the boarding diary and its Q2-hour check component. In some cases, you may have to adjust your plan for the resident's request. Just document that even after education related to the benefits of completing Q2-hour checks, the resident agreed to 2 checks at night, maybe at 1 a.m. and one at 5 a.m. I visited a nursing home recently that was still doing Q2-hour checks on everyone who was incontinent. Old habits die hard. Again, a way to focus on individual and resident-centric care, a specific toileting program should decrease the checks, improve sleep patterns, and decrease the time spent on other valuable night activities, like hydration, safety checks on frequent callers, and activity engagement for insomnia. In talking to the LNAs in that center, we learned that 2 of the 4 low-risk residents were always continent during the daytime, and the staff could save time by just working with the evening and night staff and the resident in developing a personalized toileting plan for their shift. No sleep for the residents and less work for the LNAs. Choosing your residents for your boarding diary. Let's not be asking our staff to do boarding diaries on people who are not likely to lessen their incontinent episodes. Look at the low-risk residents that are identified from your task per resident level quality measure report. I think I know what some of you are thinking. You're looking at that low-risk resident who is going to lie back and be totally dependent for all care, regardless of how much education you provide about the risk. Good luck with her. Wish I had a miracle for you. It seems there's one everywhere, maybe 2, but don't quit on her. Treat any contributing factors, for example, depression, and continue your efforts at motivating her. Keep educating and keep documenting. The minute this lady experiences a complication from urinary incontinence, she will become a survey nightmare. So documenting your continual work with her is really essential. So again, don't focus on your high-risk people. Look at your people who are not severely cognitively impaired, who are not totally independent, and who are willing participants in your program. Where to begin? Okay, we've already talked about gathering some data from your Casper level quality measure report. The other place you should check is your CNA, LNA flow sheet. These should look a lot alike, but you may find someone who has a new problem with incontinence that can be reversed. Use these tools to determine the most likely to succeed and determine your goals for the unit. Tips for completing an accurate boarding diary. Review and revise your policies and procedures as you need to. Provide your staff education and relevant resident education, and look at an all-hands-on-deck approach. Identify an LNA or a CNA continence champion on each unit. Delegate the charge nurse on every unit, on every shift for accountability. Consider keeping that diary on the med cart. Delegate the nurse manager for daily oversight of the diary. Maximize communication. Color code it. Have it on its own clipboard. Yellow is a nice color, and it's punful. Get it? Punful? Never mind. Shift-to-shift review and report. Make each diary a big deal. Assign toileting plan coverage for staff, even on their meal breaks. Keep it on the med cart so the charge nurse is responsible for completion, and she has that visual reminder to either do the check herself or make sure that the LNA-CNA is doing the check. Remember to choose the most likely to succeed. Success breeds success, and the staff need to see it. So look for those residents most likely to cooperate. When you're looking at equipment needs, we're talking about urinals, commodes, bedpans, call bells everywhere, not just in bed. The challenges in care delivery vary from shift to shift, and we need to listen, acknowledge, and respond to them, or we cannot be successful. Find an off-shift champion on evenings who will be willing to take ownership and communicate information about the boarding diary with the day and the night shift. One is enough. It's tough to get what you need to do a truly individualized plan. So one at a time. Avoid weekends and holidays in your 72-hour boarding diary. I think that sort of speaks for itself about weekend staffing. Need I say more? I don't think so. One LNA told me that her residents were incontinent because she had 4 to assist to the bathroom after breakfast. They were finished eating, ready to go, and she was still feeding residents. She was unwillingly set up for failure. So be sure that you're getting their input about their assignments and talk to them regularly, because we know that care needs change rather rapidly in our environment. So there is continence and then there are continents. And Webster says that continence is self-restraint, and we don't use restraints in long-term care. And we must all be very tired with this very exciting topic of urine and stool. I know I am. You all deserve medals. World travel would be so much more fun, but hang in there, we're almost finished. Congratulations, you have it. Just a few more things to do. Test and monitor and review your efforts in 2 weeks. So is the individualized toileting plan working for the resident? If it's not working for the resident and the team's satisfaction, go back to the drawing board. One step at a time until you meet your goal. We all know how frustrating it is to implement a fix that really seems to work well, and then we check in 6 months and somehow it disappears. So think about sustainability. Monitor your successes, and an easy way to do that is just kind of keep an eye on your quality measure in your CASPER report. But to help sustain your progress, make sure that everyone's involved, that new staff members are oriented to your processes, and that current staff members are re-educated as needed. So sign of aging number 23, you're dehydrated and yet you're up all night. It just doesn't seem fair, but there you have it. I've heard from some that limiting PM fluids has helped nighttime incontinence. Just a cautionary note, many elderly, as you know, are at risk to dehydration, and any kind of fluid restriction can be risky and should be planned in accordance with the resident's wishes. Sometimes we limit our own fluids to improve our sleep, but we do not have the same risk as nursing home residents, who are usually dependent in one way or another for their fluid intake. So if it's this resident's wish that they want to limit their evening fluids, document it as such as the care plan, and then monitor carefully. A little off the topic, but not really, we'll take a quick look at indwelling catheters as a quality measure. I can't resist the urge. Sorry, I just can't help myself. oh no, that makes me lacking restraint, and that means I'm incontinent. So Webster, oh please somebody help me. Enough already. Back to business. I know none of you are using catheters without medical justification, and you're all pretty familiar with them. Interestingly or not, medical justification does not exclude indwelling catheters from your quality measure. To have them excluded from your quality measure, and by the way, they do affect your 5-star rating, the MDS nurse must have a documented diagnosis of obstructive uropathy or neurogenic bladder. So, especially for your gentlemen with PH, check your problem list of diagnosis, get the supportive assessments and consult in the records that document retention, and then get that obstructive uropathy or neurogenic bladder diagnosis from the provider so that the MDS nurse can get it documented when she does her deed. Now, Nancy's going to offer another polling question. Thank you ahead of time for participating.
Thank you, Gail. So we're ready for our next polling question, which is, do you currently have or have you in the previous year a PIP in place related to urinary incontinence? Please select yes or no in the the panel on the right-hand side and submit, or push the submit button on the lower right as well. So we'll give that just a couple seconds to tabulate your responses.
Hello. I'm sorry. I forgot.
Okay, so we'll give that just a minute to get our responses, and then we'll move on.
I don't know. This is Yep. Yeah. That's not supposed to work for normal. She said she used to work it here in Scotland Garden, and she will come.
Okay, I think we have our feedback there, Gail. Looks like we're almost kind of 50-50 with those who responded.
All right, thank you, everyone. So looking at QAPI, you've already done all of the work. So for those of you who have it started, that's terrific. For those of you who don't, just think about what you've done already. You've identified a problem from your catchment area. You've gathered the data. You've formed a team. We've talked about participation of administration, your managers, staff nurses, maybe the staff development nurse, LNAs, the residents, and the MDS nurse. You've got a goal. You've put into words, either a reduction of UI episodes or a decrease in the CASPA percentage of UI for LowRisk residents by so much over a chosen period of time. Your root cause analysis, your team has already asked the questions, why are low-risk residents frequently incontinent? Why, until you get down to your individual root causes. Interventions are in place. It could be a review of policies and procedures, the implementation of some revised tools, your staff education, resident education, that you've purchased some needed equipment. And you're going to measure your effectiveness with reassessment after you've implemented all of these great things, and there you have your PDSA cycle. Did you meet your goals? Do you need to adjust your plan or your interventions? And once you get this into your quality format, there's nothing left to do but brag to your surveyors when they come around with their new quality-related surveyor guidelines. Our Part 2 webinar is June 30th. This is a sharing webinar. We hope to have a center come in and talk about their success story. And we would like very much for you to share any communication tools that you have with us, any boarding diaries that have been successful, your success stories, your challenges, and your questions. And Nancy has our final polling question of the day. And I believe in this one, you can choose more than one answer. Right, Nancy?
I believe so. That should be correct. This will be helpful for our next Part 2 webinar. So our question is, I would like more information on bowel incontinence, assessment tools, formal bladder training programs, or I have enough resources. Once again, please make your selection in the right column and then hit the submit button on the lower right.
Sorry, I was watering you. I appreciate it. Thanks so much. Bye.
Okay, and we'll wait to hear these see the feedback. Okay, great. With some nice feedback there that will help us inform our next program. So thank you very much for participating in that survey, that polling question.
So I just want to chat a little bit about the importance of staff stability with quality outcomes. That we know that in order to get all of these great programs up and running and successful, you need to have staff stability. So please don't miss our staff stability affinity call. We have one today. We have one that occurs on the second Thursday of every month. So you can join, invite your HR person, leadership person, corporate people to listen in. The call-in number is listed there, 888-895-6448, and the passcode 153031196. Affinity Groups, we have several of them going. These are call-ins that you can participate in. On the first Tuesday of the month from 10 to 11, we do one on unnecessary antipsychotic medication. On the third Tuesday of the month from 10 to 11, reducing resident pain. And as I previously mentioned, on the second Thursday, staff stability. You can visit the nursing home section and our website to get more information. So that finishes most of this presentation. We'll take a look at questions that may have come up in chat.
Gail, thank you so much for an excellent presentation. I am looking at chat right now, and I don't see any questions at the moment. But I want to thank all of you for tuning in to our webinar today. And I do have just a few last-minute announcements before we end today's call. Please remember that you can contact your state lead at any time with questions. We have them listed there on the screen at the moment. And when you close out of this webinar, an evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you are currently sharing a computer with someone else, you will receive an email tomorrow morning with a link to the evaluation as well as the link to the event page on our website. The PowerPoint presentation from today's presentation by Gail is posted on our website, which is www.healthcarefornewengland.org. And within the next few business days, a recording and transcript from today's presentation will also be added. Don't forget to register for Part 2 of this webinar on June 30th. We do expect to have nursing home teams share their best practices. We have some guest speakers coming on, and there will be more time for you to ask your questions, including any questions you may have from today's webinar. And lastly, we are going to be announcing later this summer, but we're planning to have an affinity group or sharing call on urinary incontinence and bowel incontinence provided by one of our physicians that works with us. And that announcement will be forthcoming. Will be a monthly call that we hope will be helpful. So if there's no other last-minute questions, I believe we will end the call. And thank you for joining us today and for all you do every day. And Gail, thank you again for a wonderful presentation.
Thanks, everyone.